Good evening, good morning, good afternoon, everybody from wherever you are joining us. It is my pleasure to welcome you to our webinar today on cancer control in conflict zones, spotlighting the key challenges of cancer survivors and leading with experts' voices in the region. The webinar today is co-hosted by the Eastern Mediterranean NCD Alliance and the MENA Coalition for HPV Elimination as part of the London Global Cancer Week for 2025. Without further ado, I give the floor to our host, Dr. Fadil Ibtihal, founder and chair of the Eastern Mediterranean NCD Alliance. The floor is yours, Dr.
Thank you, Dr. Balqis. Thank you, everyone, for joining us, and greeting to you all. We are delighted and first I would like to thank the London Global Cancer Week team for hosting and providing this platform for us. And we are delighted. This is the 5th year we are joining London Global Cancer Week for a session related to the Eastern Mediterranean region. So for today, we also very happy to have very eminent speakers and people who are going to talk about the topic related to our region, which is cancer care in fragile settings. Before I will start, I want to say a few words about our objectives and our association. So let me project my slide. We are expecting soon Dr. Zainab Begadou, the UICC president-elect. Also, she will be joining us to provide her opening remarks. So meanwhile, I will be sharing some slide with you to talk about the session, the objectives, and what we are after in this meeting. Ali, I understand some people are not able to join. Can you see my slide? Can you see my slide? Okay, good. Thank you.
But it's not in presentation. Yes.
Yes, okay. So this year we are focusing on cancer in a fragile setting, and I'm very happy to put this photo from NCD Alliance publication that is neglected in a crisis, and hopefully it will not be neglected as a cause for our discussion. Few words about our NCD Alliance. We are a network of civil society organization working in the area of non-communicable disease prevention, including cancer, across the Eastern Mediterranean region. And a critical and growing issue advocating for integration of NCD and cancer in humanitarian response, considering the unique situation of the region. There is an increasing, as you know, increasing in the number and size of the humanitarian crisis in the region that impacted the life of people, millions of people who are affected by cancer. So as a civil society, we have a big role in advocating for that cause and advocating specifically to raise the voice for the people who are affected from this chronic disease, and also to integrate the services provided for NCD cancer in the emergency health package. And our goal is to ensure that health for vulnerable population is upheld during the emergencies. So, as you well know, that crisis in our region is the region is facing a complex and prolonged health emergency for a long time. Many countries, and nearly over half of the country in our region, are suffering from crisis demonstrated as an outbreak, epidemic, conflict, war, and climate changes. So the situation of conflict in Palestine and Sudan, cholera outbreak, and outbreak, there is escalation of hostility in Lebanon, Syria, all this has experienced in the region. Many people are affected by the crisis. So in conflict, the crisis left nearly over 100 million people are needing a need for the urgent care. The region hosts the highest 46% of the world internally displaced population. So we have like 31 million people, that is out of the 67 million globally are internally displaced in our region. Sudan, like there is 14.3 million are displaced population. In Syria, there is 13.5 million. And in Afghanistan, similarly, in other places now like Gaza and other, the majority are internally displaced population. In addition to that, unprecedented, we have noticed recently in 2024 and 2025, there is the attack on the health services, an attack of health care professional and also the health care facility. So, for example, 2/3 of all global attack on health facility occurred in our region. And this is by itself, I'm sure our speaker will talk about it as a huge challenge currently for providing efficient cancer care. What is the situation of cancer? So the other angle we have on one side, the humanitarian disaster and emergency. On the other angle, we have the cancer. Cancer facing increasing burden in the region. And many patients in our region are diagnosed in a very late advanced stage. There is inequity in the cancer care because most of the system are predominantly private healthcare provider. So who pay can be treated. People who have no payment or on a low income, they will not be able to be treated. And also, as I mentioned, the destruction causes a very weak health system and weak health governance that exacerbate the situation. In addition, national cancer control plan are very limited and it's not well integrated into the governance system. There is a limited, you noticed it recently and you experienced there is a dryness in the overseas aid and donation and also availability of essential care services provided from overseas donor. Well, so today in our session, this is the topic we want to spotlight on as one of the key topic we as a civil society advocating for, the cancer care amid fragile and conflict affected area. We know that there is a global momentum behind providing equitable cancer control, and this going very strong. And recently, the UN high-level meeting on NCD, they are focusing on NCD, including cancer in a humanitarian setting. However, the reality is different in the Eastern Mediterranean region. So we are operating in a landscape where the crisis increasing, massive displacement. There is a lot of people who are displaced and also pressure on the health system, making it very hard to provide or to address the global commitment on cancer. Our objective for today, the speakers coming from, they have a long existing experience in this area specifically, and from different countries who are affected by the crisis from our region. They will provide their insight across the whole continuum of cancer care, from early detection, treatment, survival, and palliative care. And they will bring the situation, the position, and the exact situation from the ground, what happened in the fragile setting. And also we will discuss a remarkable effort to improve the situation amid this instability. So we have voices from Iraq, Sudan, Yemen, Gaza, and Jordan, and we will discuss the experience and also the operational reality of the situation. We hope that through this platform, we will be able to amplify the voices of the affected people, the voices of the affected population, and to bring this crisis also to somehow to be considered in emergency health planning. We have for you a 90-minute session. And in this 90 minutes, we have, as I said, a list of eminent speakers. We're giving 10 minutes for each one to speak about and to provide their insight from their area experience and also about their country experience. And this will be also, we will be followed by panel discussions. So we will raise with them a question related to that field. And this is the agenda as we will be moving around. So we will have, as I mentioned, this is the list of the speakers. And then we will end up with closing remark. So hopefully that's all. With that, I will go back to you, Balqis. And let me stop sharing.
Thank you, Dr. Ibtihal. It is my pleasure now to welcome and introduce Dr. Nazik Hamad, Professor of Medical Oncology at the University of Toronto. Dr. Hamad chairs Aortic Special Interest Group on Cancer in Conflict Zones and Emergency Settings, and she brings deep personal and professional insight to this discussion as a Sudanese oncologist whose immediate family are currently refugees in Rwanda. Dr. Hamad will be presenting spotlights on the key challenges of cancer services in conflicts. And Dr. Hamad, I have a gentle reminder to keep the presentation within 10 minutes. Thank you so much, and the floor is yours.
Thank you so much, Ibtihal and everyone. Can you hear me?
Yes, thank you.
Okay, so it's really a pleasure to join you, and I will try to not repeat what Ibtihal has said, but we know that at the end of 2024, there have been 123 million people who are forcibly displaced, i.e. 1 in every 67 person on Earth have been displaced, and the rate of displacement has actually doubled in the last decade. And we know that there are about 120 armed conflicts. So in Africa, we have in 16 countries about 35 conflicts, and the majority actually are a non-international character. So sometimes the conflict will be within, most of them are within the national border or within the border. And so this is sort of tells you about this is the armed conflict impact, which tells you that we have a lot in our region, including Sudan and part and Somalia is still that are in a lot of areas in the Middle East that are really impacted by conflict. Again, I would like to remind people that Africa remains the continent with the largest number of people who are forcibly displaced, accounting for 43% of the global total, and this has doubled the figure in 2016, contrary to what people believe that all the refugees are going to Europe and going to North America. Actually, 96% of refugees, for example, stay in Africa, and most of them are internally displaced IDPs. And just to remind you now, the war in Sudan is the world's largest displacement crisis, with 14.3 million Sudanese people who have been displaced at the end of 2024, including my own family. And then another thing, when we come to cancer services, we need to remember that it's not really the conflict countries that are affected, but also the neighboring countries, which we become what we call host countries. And in many cases, a lot of them have fragile health systems themselves. Where do refugees at? As I mentioned, 73% remain in LMIC, not in HIC. 67% are hosted in neighboring countries. And children worldwide account for 29% of the world population, but 40% of all forcibly displaced people, though this is the future generation being affected. And as you can see, just looking at this graph quickly, look at the number of internal displacement just from 2017 to 2025, it's almost double the number. So when it comes to cancer, the traditional way of thinking of cancer services is across the continuum, from prevention all the way to end-of-life care, and there are clinical interventions for each what do you call it, part of the continuum, clinical services, palliative care, prevention, such as vaccination. All this should be supported by policies, legislation, regulation, and programs. And a more modern way to look at the continuum is to situate it within the political economy of cancer, from prevention, screening, registry, finances, NCCP, cancer centers, and we should always add crisis management when we look at, and that's what's kind of missing from a lot of policies in our countries. So when it comes to cancer services, it's cancer, the conflict not only disrupts cancer services, destroys and decreases services across a continuum by affecting infrastructure, the functionality, and the supply chain. But what is missing a lot of time from this discourse is actually in fragile states, conflicts can prevent development of cancer care services in the first place. So when we wrote this, and what happens is that they create cancer care desert zones. So we wrote this last year as a comment in Lancet Oncology on the radiotherapy, update of the Radiotherapy Commission. And when we looked at all areas that have protracted conflicts, fragile state, such as Somalia, South Sudan, Chad, and Haiti, have very absence of radiotherapy, because most of the expansion of cancer service in LMIC happened in the last 20 years. So if you are in conflict for all of that time, you tend to have less development of services, what's called arrested development. Unfortunately, these countries, because of late presentation, they need radiotherapy more. And I'm a medical oncologist, but I would say that the factors determining strengths for support of radiotherapy need is, first of all, if there's pre-existing capacity and the geographical distribution within the country that's affected, and if there is regional and international support and mobilization, and the capacity of neighboring countries, which is how strong your neighbor can determine how your displaced people have access, and whether there is universal health coverage for that. And ability to generate data and share experience has emerged as an enabling facilitator of intervention. So what we learned from the lessons for access to radiotherapy in conflict-affected population from Ukraine, for example, in Syria, regional international support, online technical peer review, evacuation of patients from affected area, and provision of free access to radiotherapy for refugees, which is absent in many of our countries. And we did a survey that we just talked about yesterday among African oncologists. And as you can see, access to radiotherapy and access to diagnostic pathology are the ones that are mostly affected. So when it comes to cancer services, we see that in our region, surgical oncologists describe moral distress as they are asked to prioritize trauma, acute care, child and reproductive health. There is lack of access to pathology, essential cancer medicine, and palliative care, and disruption or non-development of vaccination and screening program. And it's very important to talk about the non-development and also the workforce shortages. And so in our survey of African oncologists and workforce, linguistic, cultural barriers, late disease presentation, funding shortages, financial toxicity is always higher, and then lack of access to all the services. In addition, we asked our cancer workforce in Africa to tell us what are the challenges. So the pressure on host countries, increased volume of patients versus available resources, poor follow-up, and sometimes patients and staff are kidnapped by armed group and only released after ransom, and treatment abandoned, no plan for follow-up or survivorship care. And so, from the work on integrating cancer enterprises, another framework to look at the disruption of cancer services is to look at it in the acute phase and in the protracted phase, because in the acute phase, for example, you have the displacement of population, but then the treatment abandoned them, but then long-term displacement has its own challenges, such as prolonged instability, make it access to prevention and care, as we said, and development of cancer services becomes a challenge, and also persistent workforce. So when you are looking at your own region or your own country, you need to look at the acute phase, the protracted phase, and also plan for post-recover or for post-conflict. And from the manifesto that we have published with the WHO, the 7 key recommendations, and I encourage you to go read about them. I'm not going to go over all of them, but advance inclusive strategies and care models, develop and support context-specific strategies, and to deliver better cancer care, and establish cancer care as a core pillar of the emergency response plan. So finally, what I think people ask, what can we do? And I think there is no alternative to regional, continental, and international action, especially regional. A lot of us are in academic institution. We need to tackle academic inertia. Most of the time we spend our time talking about drugs that will prolong life for 2 to 3 months, while millions of people don't have access to essential cancer medicines. We need to avoid poor planning. We empower the workforce and try to continue medical education despite conflicts. And we need to change our way of thinking into a conflict and crisis preparedness mode, and engage with stakeholders who often do not see cancer as a priority. And I can tell you from experience of Sudan, the leaders of the conflict, whether in the armed forces or the other group, a lot of them have their families outside Sudan, and so they don't really care a lot about what's happening to the people who cannot go out of the country or who are refugees in other places. As such, I think this is my last slide. We need a global paradigm shift, and we need to view cancer as a major health threat in LMIC, because it must have its place in the agenda for peace, not just for war. So thank you so much.
Thank you so much, Dr. Hamad. This was really insightful. I am pleased now to welcome Ms. Iman Shanan, a breast cancer survivor from Gaza, Palestine, and the long-standing advocate for cancer patients at the local, national, and international levels. She has dedicated her life to supporting individuals living with cancer, championing women's health rights, and raising public health awareness around cancer care and prevention. In 2009, she founded the Aid and Hope Program for Cancer Patients Care, AHP, where she continues to serve as the general manager, leading critical initiatives to improve the lives of cancer patients in Gaza and beyond. Mr. Shanan has also successfully led large-scale development programs across areas including women's empowerment, gender equality, health education, and disability rights, and she is an active member of various regional and international committees and programs. She will be presenting today her perspectives as a cancer patient voice from Gaza. So please, the floor is yours, Ms. Iman. You have 10 minutes presentation slot. Thank you so much.
Thank you so much. Thank you so much. And thank you, Dr. Ibtihal, for giving us this chance to raise our voices, to tell the story of what's going on. I will try to share.
Iman, do you need help?
No. Is the presentation
Yeah,
clear?
we can see it. We can see now.
Okay. I will talk briefly about the urgent action for cancer care in Gaza. Cancer patients in Gaza urgently need continuous treatment, safe hospitals and diagnostic services, secure evacuation and access to medical records, and also critical distribution in care violate their rights to health and demand immediate international action. Mental health and palliative care must be prioritized. Since October 7, 2023, Gaza health system has been under severe stress. 38 hospitals, 69 healthcare centers, and 197 ambulances have been damaged or become unusable. The Turkish Palestinian hospital, which was the name was Gaza Center for Cancer, shut down following militarization. Medical staff and patients have repeatedly have been displaced due to attacks on facilities. Over 1,500 cancer patients have died, averaging 10 deaths per day since October 7 because of the war or genocide. Before the 7th October, breast cancer screening in Gaza was regular and accessible. Since then, early screening has been unavailable and diagnosis occurs only by chance. This decline is unacceptable and highlights the increased vulnerability of loss of women's health rights during the crisis. Most breast cancer cases are now diagnosed at advanced stages, and as I said, it's by default. Even when patients reach diagnostic center, severe medication shortage and disrupt sessions limit treatment option as radiotherapy or PET scan are not available in Gaza. A strict travel restriction permitted only 1,100 out of 12,500 cancer patients as a register during this period during the genocide to leave Gaza for treatment. Of these, 623 exist after Egypt took control of the Rafah crossing border in May 2024. This figure indicates that fewer than 9% of those in need receive permission to leave, highlighting the extent of bureaucratic delays. When we talk about crisis overview, cancer patients urgently need continuous treatment, safe facilities, and as we said before about the numbers of what's happening in Gaza due to cancer issue. If we want to talk about many challenges that faced by cancer patients, we are talking about destruction of hospital, diagnostic center, attacks have forced hospital and staff to relocate or re-evacuate. Thousands of cancer patients are unable to complete their treatment or access essential medicine. The loss of medical records and data fragmentation. Also, none of Gaza patients now can find his medical record. Patients are leaving Gaza with only few obtaining permits, and these delays worsen the health condition. Early detection and the programs have halted. By the way, since the 7th of October 2023, none of Gaza women went for early detection, power problems, road blockage. All of these things made things worse for the cancer patient. We are talking about people or cancer patients who used to be before the war in fragile system, and 65% of services were delivered outside Gaza. Some numbers about heaven that I mentioned before. We are talking about access and payment barriers. Also, we mentioned the number. Role of local NGOs or CSOs, experience on the ground. Local NGOs in Gaza are trying to find ways to community health and resilience, provide health care, distribute medicines and supply when it's available, offer emergency medical and psychological support, deliver essential, especially when hospitals are damaged. Local NGOs track community needs, advocate for patients' rights, as I'm doing now, restore services, and educate on health and safety. And especially, we are talking about communicable disease that spread during the genocide.
Iman, can you put it on slideshow, slide mode? Is it possible on that button? Yes, thank you.
Yeah. Destroying hospital, displaced medical staff, only one function mammography machine, mental health crisis due to trauma and lack of support, power outages, and blocked road disturbing the supplies. If we are to talk about adapting solution or what solution we need, I think we have to enhance cancer care in fragile and conflict affected areas, which is required practical, flexible, and locally driven strategies. This involves increasing direct fund for community organizations that are best positioned to respond quickly when system broke down, creating multi-stakeholder emergency task force, including the Ministry of Health, cancer survivors, patient advocates, NGOs, humanitarian partners, donors, clinical leaders can help develop regular update, contingency mitigation, and continuity plan. Since cancer treatment can't be paused during a crisis, these plans must be adapted by and dynamic to ensure rapid coordinated response. I think it's very important that we have to find a clearly safe zones for cancer care and deploy mobile clinics along secure routes to provide follow-up care, symptoms management, and basic diagnostic to displaced community. Establish monitored and secure pathways for delivering chemotherapy, pain medication, and diagnostic supply. Distribute portable ultrasound and biopsy kits to active sites and enable remote expert consultations when specialists are unavailable, create clear triage guidelines for urgent cases to establish a dedicated system to coordinate medical evacuation. There are many operational recommendations, but I want to highlight something that most of oncologists were killed, pathologists were killed, radiologists were killed. So I think Gaza needs a new continuum of health, a new action plan and reaction plan. I will not talk a lot about operational recommendations because everyone who work in NCDs in conflict zone or fragile areas will know about this, but I will tell you a story from Gaza.
Is it okay or you need help?
No, did you see the film?
Not yet. There is only your slide.
Okay.
Yeah, yeah. So just to press on. Uh, Iman, if it is not working, we can move to the next
works.
speaker. Huh? Yeah,
works.
I will send it to Ali. He will present it later. So thank you. Yeah. So
Okay.
over to you, Balqis.
Thank you so
Thank you so
much, Iman. Now it's my pleasure to welcome and present Dr. Nahla Jafar, Technical Officer at the WHO EMRO, or the Eastern Mediterranean Regional Office of the World Health Organization. She's specializing in cancer palliative care, and she's a clinical oncologist from Sudan, trained in radiation oncology in Milan and Halle. She completed her master's degree at King's College London in 2019, and she founded Sudan's first palliative care service. Her contributions have been recognized globally by the American Society of Clinical Oncology and the American Academy of Hospice and Palliative Medicine, where she received the International Development and Education Award in Palliative Care Award and recognition as a World Visionary, respectively. She serves on the boards of the International Association for Hospice and Palliative Care, as well as the African Organization for Research and Training in Cancer, or AWORTIC. Dr. Jafar will present today the spotlight on cancer oncology services in Sudan, focusing on palliative care. So the floor is yours, Dr. Jafar.
Thank you so much. Thank you for the wonderful introduction. It's a pleasure to be with you today. And good morning, good afternoon, good evening for everybody who's joining us from the Eastern Mediterranean region and beyond. And it's great to have you all here for this talk. And I hope that I can speak for the voice of people from Sudan as well as for my work in WHO. So I would like to start with the importance of palliative care. It's without palliative care and inclusion of palliative care in primary health services, we cannot speak about universal health coverage. It is essential, it's fundamental, and for cancer patients to provide palliative care from the moment of diagnosis makes huge differences in their lives. Unfortunately, in the region, Eastern Mediterranean region is not faring the best. You can see that with this gray color, it is doing worse than most of the other regions in the world. And we hope things are changing slowly. This is a reality. Unfortunately, we have more than 2.4 million people who need palliative care but cannot access it. And both adults and children, this is the data from the Atlas of Palliative Care in the Eastern Mediterranean region that just came out in October this year. And here you can see all these countries in gray and light yellow, which means that there are very limited services per population. And the same is for adults as for children on the right. But we have a good news for you. On the 16th of October 2026, a palliative care technical paper and resolution for the whole region has been passed. And we hope this makes huge strides and pushes services in the region, in these 22 countries. And one of the steps that was taken to reach to this resolution was stakeholders meetings at each of these countries, where we asked representatives from Ministry of Higher Education, representatives from primary health services, NCDs, pharmacy department, cancer services, all to sit together on the same table with palliative care providers, both if there is an association or public services or even from NGOs. And we came up, and at the end we had this wonderful paper and this resolution. One of the outcomes also was that some of the countries pushed ahead. So in Iran, they decided to have this meeting every month for palliative care development. I'm happy also to share other good news from the region. In Yemen, I think it was the 13th of October, they inaugurated a palliative care service in Aden, in a women's cancer unit, oncology unit. in Iraq, we had wonderful training conducted by International Children's Palliative Care Network, where we trained, I think, more than 40 health professionals from 3 different pediatric palliative care services, and we had the workshop for access to opioids. So training and availability of medications, these are essential pillars to advance palliative care. And on the lower right here, we have this group of health professionals, doctors, mainly pediatric oncologists. They were also having a training. It was a 2-month training, and they had 4 hours of sessions every week in pediatric palliative care. So WHO is doing a lot of publications, very useful. And I would like to emphasize on another document, which I don't have here, but it's very important, and it is a framework for action on NCDs during emergencies. This one is very important because they mentioned, and palliative care is clearly stated during the different phases, during the preparation, during the emergencies, and in the recovery phase. Now I'd like to take away my hat of WHO, and I'd like to speak about my experience as an oncologist providing palliative care in Sudan, and especially after the war. So on the top here, you can see this is the nurse who's wearing the white doctor's coat. This is a nurse trained in palliative care. He's handing a paper to the care provider of an elderly patient, and I think this is her son. This lady is coming from very far away, and he's explaining to him how to take the oral morphine. And the nurse who's sitting on the table is a little bit astonished. Why is the nurse spending all this time explaining and explaining again? So I'd like to say that having a palliative care service provided or within the oncology center was a huge change to the patients, because we managed the simple things, the things that changed a lot for the patient's outcome, the symptoms, the explanation, because most of our patients can be illiterate. Okay, so during the last 14 years, this service developed in the center, in the main oncology center in the country, and we were dealing with patients. We had the ward, we had outpatient service, and we also had a limited home care service. One of the also very wonderful inputs or outputs of this service is that after the 6 years of the start of the service, we had a recognition from the oncology training program that this is very important, and oncology residents were rotating in the unit. So all oncology residents had to do like 3 months minimum with the palliative care unit. And then the war happened. It happened suddenly. A lot of people were trapped. We had a painter who was trapped in the National Museum, and he was trapped there for several days. He had to eat his paints because there was nothing. There was a sniper on top of the museum. I was one of the fortunate people to move quickly. Unfortunately, that didn't have to happen to all of our staff. We had a nurse who was taken from home on gunpoint to go and treat a militia soldier. After that incident, because she stayed in Khartoum, I think she stayed for 3 months. During all this period, there's no internet, no electricity, no water, no transport. It was dangerous to move around. But after this incident, she was like convinced to get out, and she went out. Our task was to reach to all our patients, but also to reach to our staff members and give them direction, give them advice where to move, where to continue their chemotherapy, where to get the radiotherapy, because at that time it was only in one center in the north of the country, and it's very expensive. But still, now I think it's more than 2.5 years from the start of the war, still everybody is suffering. Not only the people inside the country, but people who managed to travel outside. people inside the country, even if they are in a safer place, they are facing extreme living conditions, high prices of everything, all commodities, food, rent. Their bodies became weak, and this especially happens to cancer patients. My colleagues who are still working there, they mentioned that when they give chemotherapy to patients, they have more side effects and they see a lot of mortality, higher mortality than before the war. And of course, lack of medications and medical care. I think it was almost 26 hospitals bombed in the first 2 weeks of the war. Just imagine the destruction and the infrastructure. And when we are speaking about cancer management, we have to remember the timely and sequential order of the chemotherapy, the radiotherapy, the surgery. And as my colleague mentioned, a lot of staff, very talented staff, left the country. So now there is no the specialized surgeon like orthopedic oncosurgeon, not there. And a lot of other specialties are totally not available. And for the people who are who traveled outside, living as a refugee is not a nice situation. You have limitations on your travel. You have difficulties of work. You lose all your social network. You have difficulty acceptance into the new environment. And I'm speaking also especially for people who had to move to countries with different cultures and different language, like Sudanese people going into Uganda or going to Ethiopia. You know, not everybody can speak English. Of course, there is a lack of job opportunities, and several incidences of suicide happened. I had reports of that. The photo here shows how an outbreak of dengue fever affected people, and these are like they are staying in a place near to the hospital to get IV because the hospital is condensed. So what happened to our palliative care team? As I mentioned, first of all, we felt it's a duty to reach to our colleagues, check on their security, give them advice, but also reach to our patients. We collated all the telephone numbers that we had because it was a good practice from our nurse. Whenever a patient was given oral morphine, she was taking the telephone number, she was checking the second day, how was it, and she was affixing the dose. So that helped that we had this large number of numbers that we can ring to them and know what is happening to the patients. And we started collating the situation of our patients, replacing the electronic documents, because we had a very nice system on the computer. And now our staff in different cities are writing on ledgers, you can see on the right, and taking photos of these ledgers, sending them by WhatsApp, asking what you call it, advice from senior people, and dividing the work among the team. And so we had this nice work network, called it Project Sunshine Under War, and several NGOs supported this service. We managed to reach to 800 patients. And the staff who are dispersed now and providing palliative care in the different cities, they see patients at their homes, they go to the main hospitals, they introduce themselves to the staff there, they see patients in the different wards. Now they became known for good care, and even newly diagnosed patients are referred to them and consulted. And we are in the phase of training others, because the original team was 8 members, and now we are training 5 more online courses, so to expand the work and reach more cities. And I'd just like to end here with this example of the network and how it benefited the patients and also kept our staff busy and useful. Thank you so much.
Thank you very much, Dr. Nahla, for this great insight on the situation. I have many questions for you, but I will leave it later for the panel discussion. I have a pleasure now to introduce Dr. Zainab Bagadou. She is with us now. Um, she joined us. She is the president-elect of Union for International Cancer Control.
Dr. Jen, I don't see her.
She said she is there. So
Yeah, she just joined now.
okay,
Admit.
great, Dr. Zainab, great having you. And if you, Ali, if you allow her to join us as a speaker, please. So let me introduce Dr. Zainab, Her Excellency. She is the President-elect of UICC, and she is known as the mother of health in her country. She is a pediatrician by training and champion for women and child health. Dr. Zainab also, she is the founder and CEO for Medicaid Cancer Foundation. That is the forefront for fighting cancer and against cancer. So she's been known globally as a long-standing cancer control advocate. And I am very pleased that we always happy to have her working as interregional, and she is always giving us the word of wisdom and insight and keep us inspired for fighting cancer. So welcome, Dr. Zainab, and the floor is yours. We want to hear from you, especially on cancer control, and if you can focus also on the issue related to our region. Thank you.
Hello, everyone. Good afternoon. Greetings from Nigeria, Abuja in particular, and it's an honor and a privilege. I hope I am quite audible. I'm sorry, I just had to quickly join on my phone because of the the notice was a bit short, but I was very happy to join this very
Thank you for that. You always.
Yeah, it's an important thing and one that we keep talking about, the issue in fragile settings, and especially as it relates for us as advocates in the cancer space. It's I've been, like you heard, I've been a long-standing advocate for equitable cancer control and cancer care, and I remain deeply committed to a vision of ensuring that whether we have political stability, instability, we try our possible best to improve cancer control and to deliver the vital services to people that need it. And this is across the entire spectrum, whether you're talking about prevention services, awareness, outreaches. We saw what's happened during COVID, and in a way, something like that. But in countries that had the resources and the ability to react properly, it was soon overcome in 2 to 3 years. But in regions like the MENA region, like in my country, Nigeria, we're seeing increasingly unstable areas where we cannot deliver vaccination for cancer and for even childhood immunizations. We cannot deliver screening services because the healthcare professionals are not traveling to those areas. And the issue and things that are happening in places like Sudan, Gaza, and so on, it's really very pathetic and breaks my heart. We just recently had so many issues, I don't even know where to start, and we can all get emotional here. But the important thing is that as professionals, we come together and we amplify the problems that we see in our daily practice. There is no better person to do it. Where I think we fail is we always talk to ourselves. At the most, we have advocates like myself who sits on the level of a doctor and an advocate, or like pure advocates, but we do not engage the politicians, the lawmakers, even our military. Right now, we're running a program in Kebbi State where we're trying to deliver polio was eliminated in Nigeria, and then after some years, we started seeing a resurgence. So one of the foundations supported and funded a military-backed polio delivery. So there are areas, 19 areas. We started at 8 local government areas out of 21. Today, there are 19, 3 years later, whereby you have to have military support to follow the vaccinators to go and deliver childhood vaccines. So we are not even talking about HPV in those areas or hepatitis. Yes, hepatitis for the children is there, but it's not being delivered as it should be. So my point is we should try to involve the other stakeholders that can help to really do a different plan. We're not politicians and we're not going to make the peace in the regions, but we want to continue doing our work. So we need that support and we need that environment to enable us to practice it safe. So I hope that this kind of meeting, if even they don't attend, we can disseminate the information or the outcomes from our deliberations to them, and I'm sure that they will be. We can get some impact, something done at least. So I thank you for all the dedications. My dear friend, Dr. Fadil, it's so good to see you all the time and always working hard for NCDs in the MENA region in particular. And we look forward to hosting you in Nigeria or West Africa one of these days. The next UICC World Cancer Leaders Summit is going to be in Kenya, a region that is quite stable. So I hope that some of you will be able to attend, and we keep on praying for our brothers and sisters in areas that are facing conflict and insecurity. Thank you very much.
Thank you very much for these great, insightful words, and thank you for your joining us with short notice. But I know, and I'm counting on your advocacy, and I know this is your mission, and let's work together. Thank you very much. Thank you.
Thank you, Doctor.
Thank
Have a
you.
great
Over to you, Balqis.
Thank you so much once again, Dr. Zainab. Now it is my pleasure to present Ms. Rana Ghaffari, Head of Advocacy and Government Affairs at the King Hussein Cancer Foundation and a member of its Executive Management Committee. Ms. Ghaffari has played a key role in shaping national and regional cancer policies, leading strategic advocacy efforts and championing reforms such as the University Scholarship Policy for cancer patients and expanded coverage for breast cancer screening. She will be speaking today on the role of the key HCC in cancer services for refugees. Your presentation is 10 minutes, so the floor is yours, Ms. Rana.
Thank you so much, Balqis. Thank you, Dr. Abtihal, as always, for bringing us together in this a week to advocate for cancer patients worldwide, and specifically in the context of crisis, where there's much need for us to zoom in on cancer and cancer patients, where unfortunately they suffer double the burden of the disease. As mentioned by Balqis, I will be talking about our humanitarian response action plan for cancer patients, specifically for our brothers and sisters in Gaza, where seriously they've been undergoing very severe conditions. On top of that, their cancer diagnosis. I want to start by saying that King Hussein started its humanitarian funds not only for Gaza. We started years ago. If Ali, I can have that in the second slide. It talks in this slide. You can see that from 2003 to this day, we KHCF used the Goodwill funds as a tool to ensure equitable access of cancer care for less privileged communities, refugees, displaced people, and over multiple crises. Unfortunately, our region suffered from multiple crises over the past decade. And as you can see here, we were able to bridge the gap for cancer care for more than 6,000 cancer patients, or with a total cost of over 142 million Jordanian dinars. And because we're focused on dignity preserving coverage and access to cancer care, our interventions, they don't only cover treatment, but they also cover treatment supportive services to ensure that our patient is comprehensively hosted for cancer and accommodated for all their needs. It includes also accommodation needs, livelihood expenses, anything that basically provides an enabling and supportive environment, and most importantly, rights-based access to care. Of course, this was all for all refugees, but of course, in our next slide, I will show what we've been doing for Gaza in specific. Unfortunately, the dire situation in Gaza started even before October. I mean, as you can see here, we've had our Gaza Goodwill Fund starting 2018, where we worked with covering treatment for more than 157 patients throughout these years, and this required a lot of support, a lot of advocacy and resource mobilization on our part with our network of partners and loyal supporters. However, the situation took a much worse turn after October, and that's why we had to plan an advocacy response to tailor to what happened after the man-made crisis, I have to say, in Gaza. In our next slide, you will see that we planned our response plan to the crisis at multiple levels and multiple phases, closer to the immediate crisis. Our response was focused around delivering medication aid through a lot of the airdrops that Jordan has participated in. Jordan was very keen on supporting the healthcare system in Gaza, and not only through medication aid, but also through different medical expeditions that were deployed to Gaza to support our healthcare providers and brothers and sisters in the healthcare system in Gaza. Following that as well, there was a lot of focus on basically media support, advocacy support to really bring forward to the world the gravity of the situation in Gaza and the complete annihilation of the healthcare system and what's happening in Gaza for all healthcare services, but of course as well for cancer patients in specific. And unfortunately, in situations of crisis, what happens is that unintentionally cancer I wouldn't want to say it becomes overlooked, but sort of looks like the less pressing health condition, whereby infectious diseases, traumas, emergencies, they look like more pressing matters. But again, this doesn't undermine the gravity of the cancer diagnosis. As we speak today, more than 10,000 cancer patients in Gaza have no access to treatment whatsoever, no access to palliative care, no access to healthcare providers. And these are truly scary numbers. Not only we need the global community to support and to understand what's happening, but also the main focus now should be around the reinstatement of cancer care in Gaza. And reinstatement of cancer care has more than one pillar. One would be the capacity building of healthcare providers that are still remain in Gaza. Unfortunately, during the crisis, there was a deliberate targeting of healthcare facilities, deliberate targeting of healthcare professionals, whether through imprisonment or, of course, killing them throughout the process. So, which ends up depriving cancer patients and other patients as well from access to trained healthcare providers to deliver care and palliative support as well. Now we are focused. Next slide, please. I think we are focused throughout the crisis. Initially, we were focusing around raising awareness about the gravity of the situation, what is happening to cancer patients, what shortcomings are there in the healthcare system. But I think now we're beyond advocacy and awareness, and we're trying to shift the narrative to more actions by the global community. We're working with our partners, different organizations around the globe, to shift the narrative towards actions on the ground. What is needed now is, of course, we still need to facilitate and advocate for the emergency evacuation of cancer patients. We are supporting in the King Hussein Cancer Center hundreds of cancer patients now, but who have been hosted, and I will talk about this shortly. But there's still thousands yet waiting for cancer care to be delivered. We need to advocate for the evacuation of adult cancer patients. Unfortunately, most organizations are focusing on pediatric cancer patients. Adult cancer patients are being overlooked. This is something that needs to change. We need to mobilize the global community as well, to mobilize resources towards the reinstatement of cancer care in Gaza at the level of infrastructure and at the level of human resources. If we really want to save cancer patients and we really want to make a difference, the focus should be around that. And of course, in my next slide, I would also like to share what we are currently doing for cancer patients in Amman, Gazan cancer patients in Amman. Jordan has committed to support evacuated cancer patients. So far, we have 138 Gazan cancer patients with their family members as well. They have family companions as well in Jordan. We are completely mobilizing resources and fundraising for their treatment. We've covered their treatment so far since the crisis with over 9 million Jordanian dinars, around $12 million. And again, maintaining that rights-based and dignity-preserving intervention. We not only cover treatment, but we also cover accommodation, communication costs to make sure they stay connected to their families back home. For those in school years, we were also we've managed to secure scholarships for them to continue education, whether in schools or universities, all in this in the rights preserving mindset to make sure no conflict nor cancer deprives them of the right to education. Next, please. I think I'd like to leave our audience with our main interest and call for action and call for solidarity by everybody around is our focus areas now should be around, as mentioned, mobilizing more resources towards cancer care and cancer treatment, advocating for the evacuation of immediate cancer cases from Gaza. Both adult and pediatrics, adults should not be left behind. The reinstatement of cancer care, if we really want to do something proper and really to help most cancer cases, we have to focus on the reinstatement of care. Healthcare facilities need support in terms of infrastructure, medications, equipment, health. The emerging medical leaders and providers in Gaza have had, some of them unfortunately have lost their mentors and their specialists who they were training them. So this is why in the region and globally, we have a commitment to train and build the skills of these emerging healthcare providers to make sure that cancer care in Gaza is reinstated to make sure we can save lives moving on. Thank you.
Thank you so much, Ms. Rana. This was really insightful and inspiring. Thank you for all the support you've been giving to Gaza from Jordan. Now it is my pleasure to welcome our next and last speaker, Dr. Laith Mullah Hussein, attending physician and clinical assistant professor at the Cancer Center for the North and the University of British Columbia. He is also a regional advisor for Eastern Canada to the Royal College of Physicians of Edinburgh. Dr. Mullah Hussein is certified in radiation oncology by both the Jordan Medical Council and the Royal College of Physicians and Surgeons of Canada. He has authored over 1,100 publications, and has contributed extensively to radiation oncology education, global oncology ethics, and the establishment of Iraq First Radiation Oncology Certification Board. Dr. Mullah Hussein will present today the spotlight on the challenges of cancer research in fragile settings. So the floor is yours, Dr. Laith.
Thank you, Dr. Balqis. Thank you, Dr. Ibtihal, for the invitation to share this insight. Is my slide are shareable now?
No, we see your screen, but not the slides.
Now?
No, it's still on Teams, so we see the Teams from your side.
Okay. Can you share it from your end? So
yeah, of course. Don't click on the now it works. Yeah,
it works now. Yes.
now it works.
Yeah. You need to put it on slide mode.
No,
we're sharing.
I shared
we're
it.
sharing. Yeah, we're
Okay.
sharing from our side.
Yeah. Thank you.
So it's my pleasure to share my spotlight about the challenges of cancer research among fragile settings in the MENAT region, Middle East, and North Africa and Turkey. Next slide, please. This is just my disclosure. Nothing special related to this presentation. Next slide, please. Actually, it's an overview about the research work that we did published in 2023 at the JCO Global Oncology about cancer research in vulnerable populations, a call for collaboration and sustainability from MENAT region, Middle East, North Africa, and Turkey. Next slide, please. Next. So all of us know that cancer is a major burden across Middle East, North Africa, and Turkey. Many MENAT countries experience multiple conflicts that compound vulnerabilities, but little research investigates the linkages between vulnerability and cancer research. This study examines the current level and the potential for cancer research among vulnerable populations in the MENAT region, and aiming to provide a direction toward developing a research agenda on the region's vulnerable populations. The methods that we use in this slide, in this work, is expert-driven meetings were arranged among the 10 authors, and after obtaining institutional review board approval, a self-administered online survey questionnaire was circulated to more than 500 cancer practitioners among the 22 MENAT countries. Next. These are the participants' demographics of the study. Many of them from the age category of around 35 to 44 years. Male to female ratio is about 60 to 40%, with different oncology background, radiation, medical, clinical, pediatric, and etc. And the countries participated in this from Iraq, Turkey, Egypt, Saudi Arabia, Algeria, Oman, Jordan, Libya, Morocco, Bahrain, Lebanon, Syria, Kuwait, Pakistan, United Arab Emirates, Iran, Qatar, and occupied Palestine territory, and Sudan, and Tunisia, and Yemen, and Cyprus. Next. The results showed that 216 cancer practitioners across the MENAT region responded with a response rate around 45%. Next. 50% of the respondents identified clinical research in vulnerable patients with cancer as a significant issue. 22% around reported previous research experience that included vulnerable populations, and 60% reported encountering vulnerable populations in their daily clinical practice. Next. The main barriers to conducting research in vulnerable populations were lack of funding and lack of protected time and lack of research training, and more than half of the respondents believe that wars conflicts constituted an important source of vulnerability. Next. This is just like showing the percentages of these barriers that are preventing the research in vulnerable populations. Next. Also, to categorize the people who are like in the vulnerability scale, we reviewed this among the respondents, and the main vulnerable groups were the elderly. So research in elderly group is an issue. Most of the clinical trials, even in the Western communities, is in the non-old age groups. The palliative terminal ill patients, this is another vulnerable group. Those with concomitant mental health related issues, and those with other chronic diseases, and socioeconomically deprived patients. These are the top 5 vulnerable based on the opinion of the MENAT respondents. Next. This is the whole scale of possible vulnerable group, including the older patients, the children, the pregnant, divorced, migrant, ethnic minorities, detainees, veterans, and dementia, addiction groups, organ dysfunction, socioeconomic deprived, LGBTQ group, and people with limited. And then among the respondents, we categorize the top 5 that we mentioned earlier. Next. This is just showing the countries that we received the respondents from them, and also with the cancer cases based on the 2020 and registry from the global CAN data. Next. Also the research scale of the respondents from these countries, whether they have conducted research in vulnerable groups or not. We can see that the respondents who said yes, they are around 21%, and the respondent who said no, they are around 53%. So next. In conclusions, all of us know that cancer is a major burden across the MENAT countries, and our results support that a major effort is needed to improve cancer research among vulnerable cancer populations in the MENAT region. And we call for interdisciplinary research that accounts for the region's unique compounding and cumulative forms of vulnerability. And this cancer research agenda on different vulnerable populations must balance socio-behavioral studies that explore socio-political barriers to quality care and clinical studies that gauge and refine treatment protocols. Next, also building a research agenda through collaboration and solidarity with international partners is prime time. Next, the take-home messages from our research is that the study is the first of its type to investigate the prospect of advancing a cancer research agenda focusing on vulnerable populations in MENAT region. Research on vulnerable populations in the MENAT region remains limited because of lack of funding, protected time, and training in research methods. Conflicts forms a crucial part of vulnerability in the MENAT region, leading to a compounded impact on already vulnerable groups. And we call for robust interdisciplinary research agenda that accounts for the unique and cumulative forms of vulnerability in the MENAT region. And this research agenda must balance socio-behavioral studies that explore barriers to quality care and clinical studies that gauge and refine treatment protocols. And thank you for the attention.
Thank you very much, Dr. Laith. It was great joining you and also to present this issue, the prospect of research during vulnerability. For the sake of time, and I would like to move into one question for each of the speaker, and I will start with you, Dr. Nazik, now given that you have to leave for your clinic. So just shortly, if you have the opportunity to meet a policymaker in your country, and what shift or what policy advice you provide to improve the access of oncology care, medical care for people who are affected with the crisis. He will ask you, advise me. It's a complex issue, but he need advice. So you tell him, I think this is the policy shift.
I think it's very complicated. I think there are two levels for us. If we, let's say, look at Sudan, there is internally displaced and people who are not displaced, but the cancer care has been disrupted. And then we have people have become refugees in nearby countries. I think we can start with the people who have become refugees in nearby countries. We need to make sure that our government has good relationship, which is often not the case with our, the patients have been recently in Uganda. There was this lot of issues, even when they have access to care. We need to, work with neighboring governments, neighboring institutions, and to see if there are any treaties that we can engage in to improve the lot of our, people who are externally displaced, especially those who are displaced to other fragile health systems or to a system that may not be able to, support fully their needs. And then locally, I think it's should be actually starting before that. We need to have a little bit of conflict preparedness. We need to, like, for example, the infrastructure in Sudan, like radiotherapy, it's all being dismantled, especially the public ones. So how do we maintain, safe corridors for other entities that may help improve them or repair these machines? How do we make sure that our workforce is still able to maintain their education and also available in safe areas? And really, the patients who are internally displaced, how they will be able to be supported for housing, for access to care that is, and in general, as Nahla has said, what we've seen is that even when access is available, the nutrition and everything is affecting patients' response to even if they're able to have chemotherapy. And first and foremost is that like the Minister of Health, we need to see if they have they're really engaged with the NCCP. They're able to put cancer as one of their priorities, and then we have to make sure that our policymakers are really working for peace, because this is also another peace. We really need peace, and at a very, very high level, we need to have all of those areas in our country that do not have access to care prior to the conflict have expand the expansion, because that's one of the reasons for wars in our setting, is that a lot of people are deprived from access to healthcare, and that's why peace is really a prerequisite also for access to cancer services.
Exactly. Thank you very much. Definitely, this is an issue we will continue working on together, and we really acknowledge your advocacy and your work on this agenda. Thank you very much, Nazik, for joining us today and for contribution for this session. And hope to see you always in research and also in different activity related to the topic. Thank you very much. Thank you for your time. I would like to move also to other colleague to ask the same similar question. I mean, if you had, I understand from your area, like Iman, you are been working in this area, advocating for patient voices and the right of the patient. So if you had the opportunity to talk to the Minister of Health, what is the one ask you ask him for the sake of the people who are living with cancer?
Yeah. The main question that I will ask, why not to integrate people with that experience and patients advocate in planning and decision making? Because, and this also including the local NGOs who are working on cancer issues, because it's very important as we as advocates or NGOs, we are the supportive of Ministry of Health in this planning and in Gaza issue. I think we have to be in the beginning, because we need a continuum of health, a continuum of services, and we have to find ways how to start from the beginning with including people with lived experience, patient advocates, local NGOs, because I think it's very important that as a people from Gaza know what should act on behalf of us. We are experts and we can find ways together with the MOH to start the system from the beginning.
Thank you very much, Iman. We will keep the video as a voice of the patient to the end, because this is the best way to end our webinar, to bring the patient voice to the whole this area, the picture. Yeah, I will move to Dr. Laith. Dr. Laith, if you are currently visiting Iraq, and you want to improve the radiation oncology in Iraq. So what do you think because Iraq is rebuilding now. So they
Yes.
are moving from the state of crisis to rebuilding. So what is your advice for them? I know the situation in Iraq related, and you are familiar to radiation oncology.
Yes. So I think that now there is reasonable good progress of radiation oncology services in Iraq. I remember when I started my oncology training in Iraq in 2002, there was 4 linear accelerator at that time. And the population at that time maybe around like 25 to 30 million. Now we have about 45 million, and we have more than 50 machines now. We are like doing advanced procedures regarding stereotactic radiation therapy, regarding the advanced radiation procedures. So I am happy with the progress. Still, we need to have some like network connections between all the radiation centers. Like, for example, we are here in BC, British Columbia. All the cancer centers are sharing the network. So the cancer patients have unique identified number. We are having the same planning system. We are having the same electronic chart records. So we can improve the connection between the centers sharing in patient care, and this also will have an impactful advancement in cancer research, because all the cancer data are electronically captured. We need to improve the quality assurance and safety procedures of the the radiation oncology departments. We need to advance the training scale of the human resources. The not-for-profit support is important. I remember, like the King Hussein Cancer Center, where I joined for about 6 years, there's tremendous support from the foundation to the cancer care services. So I think this is also an additional element that can support the cancer care services in Iraq. The last but not the least is the ethical challenges. We need also to empower the ethical considerations. For this reason, I am now leading a global initiative about ethics-guided radiation therapy, EGRT, where we need to connect the ethical principles with the daily practice of radiation therapy. I think these are my thoughts at the current time for the Iraqi environment, radiation oncology.
Excellent suggestion. Excellent. Thank you very much.
Thank you.
I move to Nahla. Nahla, you've been working and visiting many countries who are affected with crisis in our region. So if there is an opportunity for engagement of local health worker, our community in providing palliative care in those countries, how do you feel about it?
Yes, I think this is very important. All countries who are in crisis, came out of crisis, or expected to enter into crisis, should have a plan. To how to provide palliative care if things change. I know the situation of palliative care now is not so good, but when we prepare ourselves for crisis is very important. And so I would work with these local health providers in training, ensuring that they have access to medications, and especially form a community or a network of service provision. We know that with information, with direction, and with support, we can reach to more patients and we can help these patients. Thank you.
Thank you very much. Thank you. Rana, I want to check with you. How do you feel, or how can bilateral donor and foundation and private sectors player can be incentivized to invest in cancer care model, especially for refugees who are currently, hosted in Jordan for a long time? So how do you work with these all sectors?
Yeah, well, definitely all partners and stakeholders need to be more engaged and more involved. I think one of the very apparent challenges that we're facing in the region is the duplication and sometimes fragmentation of work by development agencies, humanitarian agencies who respond to certain crises. And unfortunately, this reflects on patients' access, sustainability of care, and really prioritizing what needs to be done. One issue is, one area, of course, is that we need to leverage our voices. We need to advocate further. We need to call for better alignment among partners. What we have been doing so far in the foundation is that we really showcase the need for refugees in general, and in this case, unfortunately, the most recent case is what's happening for our brothers and sisters in Gaza. We put that forward in front of donor agencies, but what we're missing really is consistency in support. We're missing alignment between donors. We're missing focus on the critical interventions needed. We collectively, as a global community, need to stop being incentivized by fancy numbers, propagandas, and jumping from one, I'm sorry to say, trending crisis to the next. And this is something that we're facing. It's far from realistic to assume that the crisis in Gaza is over, or the crisis in Syria is over. there's still a lot to be done at so many levels. So I think we need to focus on data, sharing proper data with donors, make sure we communicate properly with donors, and really make sure that we are aligned to avoid duplication. And most importantly, engage the partners on the ground. One of the main issues that we are witnessing now, for example, specifically in Gaza, is that we can't, as humanitarian agencies or development agencies, come in and assume that we are going to, replace the role of the nationals, the locals. We need to work with the partners. We need to work with the healthcare providers and the institutions on the ground in Gaza to rebuild the system. This is something that we need to keep in mind as we move forward if we're looking for sustainable impact and relief of this crisis.
Thank you for all your effort you are doing on the ground, and please continue because it's much needed for the sake of our brother and sisters suffering this disaster issue. So at the end, we have said a lot. You have said a lot, and there is a lot of messages coming out of our today discussion. The things which we want to focus on, that the journey of the cancer patient is different where you are living now. So this is make a difference that if you are in a crisis or you are in a stable situation, and that we are lobbying and advocating for having equity of service even if you are in a crisis, because the cancer is a cancer, has no border. And this is our mission, and definitely we will continue that mission together, and we will continue advocating because it is a complex and it is a triple burden: cancer plus disaster plus crisis. I will stop here, and I want to share with you the video of a voice of a patient suffering from cancer in Gaza, and this is how we want to end our webinar. Before that, I would like to thank you all for your insight, for your wisdom, and for your sharing your experience. It was great, and we truly appreciate it, and for your time also. And I want also to thank the organizer and the team of the London Global Cancer Week for providing us the opportunity to join and put our voices on the global agenda. Thank you very much, and enjoy and keep you with the voice of a patient from Gaza. Thank you. Over to you, Ali.
مريضة كانسر بعاني من قلة العلاج والأدوية. حتى الآن أنا بعاني من نقص الحديد في جسمي 3.5، مش ملاقي علاج آخذه بالمرة. وكمان بعاني نفسيا من النزوح، نزحت 3 مرات، بعدين روحت دمار بيت كتير. حتى بعاني من الرئتين تبعتي من سنة من أول نزوح إلنا من النار اللي بنولعها. لو أنا بقعدش كمان جنب النار أنا بتأثر في الريحة اللي حواليا. وكمان اكتشفت أختي أصغر مني في شهر يناير 2025 السنة هذه كانسر ثدي. تغلبت لما عرفت إنه معاها كانسر ثدي، بعدين عملت العملية، وبعد العملية أخذت كيماوي. هلقيت هي بدها إيش؟ بدها إشعاع أو بدها صورة مسح دري على سبيل تطمن إيش فيه. هن عملت CT قالوا لها كويس بتاخذ العلاج الباثيولوجي. العلاج الباثيولوجي بكفيش، لازم بدها هي تطلع برا تعمل إشعاع، تعمل مسح دري، تعمل تحاليل. وأنا كالمثل إلها، يعني أنا من 2018 ما عملتش لا تحاليل لا صور. عملت صورة جديدة CT التراساوند وCT على رقبتي، طلع كتلة تحت يعني عند الفك. قال الطبيب انها يمكن كتله هرمونيه، كتله التهابات، يمكن خلايا سرطانيه. كل 3 شهور بدي اروح اتحكم. طب انا من اللي يعني بقدرش اطلع امشي من الردم في الشوارع، من الحجار النفسيه. انا لما بطلع بشوف الوضع في الشوارع بروح ابكي، بقعد يومين انا تعبانه نفسيا. يعني انا بطالب انا واختي وجميع المرضى اللي زينا بنعاني من هذه الحاجات للخروج لبرا على سبيل ان نتعالج برا، نعمل فحوصات. انا حقي ان انا اطلع اعمل فحوصات، يعني الي بيجي 5-6 سنين ما عملتش فحوصات، لا عملت صور، لازم حقي. حتى الاكل هذا اللي احنا اللي بناكله من مجمدات من شيء مش قادرين حتى ناكله، والفواكه اللي بتجينا ما بتفيد جسمنا، بدنا علاج، بدنا غذاء، بدنا شيء، بدنا نطلع برا، احنا مش نشم الهواء، احنا بدنا العلاج، ونطالب الكل يعالجنا. انا واختي لازم نطلع علاج. برضو كثير من صحباتي هيك بيعانوا من هذا الاشي.
Thank you for our voice from Gaza. Can we take one group photo, please? Even if the speakers, please, can you all? Even if we have, yeah. Gallery photo, Ali, please. Thank you very much, and hope you enjoy your rest of the evening, and thank you. Bye for now.